Perforation is the second most common complication of peptic ulcer disease after bleeding. However, it is the most common indication for emergency operation. It has a short-term mortality of 10 to 30%. It is characterized by morbidity 50 to 60%. And it is responsible for 40% of all the ulcer-related deaths. The approach to the patient begins by investigating the clinical history. Usually is an emergency needing immediate intervention. The information sought should be focused. Past symptoms and signs indicating peptic ulcer disease may exist, although they are often absent, and perforation is the first manifestation. Of equal importance are the comorbidities and medication of the patient, which may interfere both with his presentation and with our treatment. The prominent symptom of perforated peptic ulcer is severe epigastric pain of sudden onset. It is not unusual for the patient to remember the exact time when the pain started. Abdominal distension is also frequent. Less common are vomiting, nausea, dyspepsia, and constipation. The presence of fever is an alarming symptom because it may indicate a septic condition. Pain starts abruptly as soon as the leaking gastric juice and chyme cause chemical peritonitis. It does not subside with common analgesics, but continuously deteriorates as more fluid leaks. Initially the pain is located on the epigastrium, but later it involves the right lower quadrant as the fluid streams along the right paracolic gutter towards the right iliac fossa. If it affects appendix, it may cause acute appendicitis, a situation called Valentino syndrome. As more fluid leaks in the peritoneal cavity, the chemical irritation and pain becomes generalized. In case the leak is contained by adjacent omentum and viscera, then the pain may remain localized. Strikingly, up to 25% of the patients do not experience pain, either because the leak was sealed, or because of coexisting disease and medication. Clinical examination findings depend on the time that has lapsed since perforation. We can roughly divide the course of perforation into 3 phases. The first phase, which lasts approximately 2 hours, is characterized by epigastric tenderness, rebound tenderness, which is commonly called Bloomberg's sign, and tachycardia with cool extremities. The next phase, up to 12 hours since perforation, is characterized by abdominal rigidity and right lower quadrant tenderness. The final phase, when more than 12 hours have passed, is characterized by signs of peritonitis, with generalized tenderness and abdominal distension due to paralytic ileus, but also signs of the ensuing sepsis with fever, hypotension, and circulatory collapse. On examining a patient with possible perforation, remember that peritonitis is a painful situation. Vibrate the stethoscope at the end of auscultation, as a test of peritoneal irritation. If this causes pain, avoid percussion and be gentle in palpation. 1 out of 3 patients arrive at the operation theater in sepsis, which is responsible of approximately half of the fatalities. Early recognition and early treatment of sepsis is of extreme importance. The diagnosis of sepsis is set when infection is confirmed or highly likely, if 2 or more of the following criteria are met. Temperature higher than 38 degrees Celsius or lower than 36 degrees Celsius. Respiratory rate higher than 20 breaths per minute or PCO2 higher than 32 mm mercury. Heart rate higher than 90 beats per minute. White cell count higher than 12,000 per microliter or lower than 4,000 per microliter. In blood tests we expect elevated white blood cells, increased serum amylase, up to 4 times the normal limits, with normal serum lipase, increased C-reactive protein, hypoxemia. As sepsis progresses, the drop of blood pressure and perfusion will lead to metabolic acidosis with hyperlactatemia, elevated creatinine and urea due to prerenal injury, and coagulation disorders. Imaging examination starts with chest or abdominal X-rays. It can be with the patient erect or, if he is too frail to stand up, decubitus, either postero-anterior or lateral. Before shooting the X-ray, it is important for the patient to remain in that position for some minutes. This facilitates the accumulation of intradomial free air, which is what we expect to see. In 75% of the cases, free air can be seen as a radiolucent rim under the right diaphragm, or under the abdominal wall in lateral decubitus position. Free air can also be seen between the intestinal loops as it outlines the intestinal wall, a sign commonly called Reigeler's sign. Other signs are the football sign, which is a large round radiolucent area resembling a football in decubitus position, and the falciform sign, which is the outline of falciform ligament surrounded by air. A more effective investigation can be achieved if we augment contrast. We can inject air to the stomach through the nasogastric tube and repeat erect chest X-ray after few minutes, or give the patient water-soluble contrast orally and search for a contrast leak. Use of barium as a contrast medium is contraindicated, because it attaches strongly on the peritoneal mesothelium, and causes severe chemical peritonitis. Absence of a visible leak does not exclude perforated peptic ulcer, as the perforation may have sealed off spontaneously. A CT scan offers the solution to the diagnostic dilemma with an accuracy of 98%. CT has greater sensitivity in detecting free air, and at the same time it can reveal the site and size of perforation. It requires the patient to be hemodynamically stable, and is conducted with the patient supine, which is better tolerated. It is equally effective in patients with acute renal injury because intravenous contrast is not required to detect free air. The same signs with X-rays are sought. Free air below the anterior abdominal wall, or on both sides of the falciform ligament, or on both sides of the bowel wall. Also, extraluminal water-soluble contrast is diagnostic. Other common findings are the presence of unexplained intraperitoneal fluid, bowel wall thickening, and mesenteric fat streaking. A major advantage of CT is that it can rule out other causes with similar presentation like acute pancreatitis, and clarify cases with unclear presentation. The risk of mortality can be predicted with the Bowie score, which is based on simple clinical parameters. Similarly, it can be estimated by the peptic ulcer perforation score. This is also based on simple clinical and laboratory data, but it employs the American Society of Anesthesiology class of the patient. Given the opportunity, we will review this classification. Class 1 includes the normal healthy adults. Class 2 includes the patients with mild systemic disease which does not cause any functional limitations. The patients with more than one severe systemic diseases, and the patient who suffers from substantial functional limitation belongs to Class 3. Class 4 are the patients with severe systemic disease which present a constant threat to life. And Class 5 are the moribund patients. The indicator E denotes that this is an emergency situation, and that any delay will increase significantly the risk of death. A more accurate score is the Sequential Organ Failure Assessment Score, SOFA score. However, this requires sequential assessment of various parameters measured in an ICU environment. SOFA score predicts mortality with greater precision. Perforated peptic ulcer is a medical emergency needing immediate intervention. The primary goal is to avoid sepsis, circulatory collapse, and the subsequent organ failure. Resuscitation should start as soon as possible, ideally within 1 hour of patient's presentation. As in advanced life support, we focus on ABC, securing the airway, breathing and circulation of the patient. The goals of resuscitation are achieving a mean arterial pressure greater than 65 mm mercury, a urine output greater than 0.5 milliliter per kilogram per hour, and normalization of lactate. On the same time, blood microbiological cultures should be taken. An empiric treatment with broad-spectrum antibiotics should be initiated. Typically this consists of the combination of a beta-lactam plus beta-lactamus, with metronidazole, or ciprofloxacin plus metronidazole, in case of allergy to beta-lactams. Decades ago, Herman Taylor published his results on non-operative management of perforated peptic ulcer. Non-operative management was successful in 24 out of 28 patients, leading to a success rate of 78% without surgery. His method has been revalidated by others, with success ranging from 40 to 80%. This means that non-operative management may play a role in the treatment of perforated peptic ulcer. Non-operative management has the advantages of avoiding surgery, general anesthesia, and the post-operative complications. But this is at the risk of higher mortality rates in case of failure, and prolonged hospital stay compared to surgery. Furthermore, mortality increases significantly if more than 24 hours have passed from the onset of symptoms. And for every hour of delay from admission to surgery, the risk of death increases by 2.4%. Therefore, the choice of non-operative management should be made with extreme caution. Non-surgical treatment should be considered only for patients at lesser risk of progression to sepsis, younger than 70 years old, with normal vital signs, hemodynamically stable with heart rate less than 95 beats per minute, and with a sealed perforation in a water-soluble contrast study. It consists of nil by mouth, combined with gastric decompression via nasogastric tube, intravenous hydration, continuation of anti-secretory and PPI therapy together with broad-spectrum intravenous antibiotics. After a few days, if the patient remains stable, liquid diet can be initiated and advance slowly. After discharge, follow-up endoscopy should be performed at 4 to 6 weeks. Of utmost importance are the prerequisites for any attempt of non-operative management. These are commonly known as the 6 R's. Radiologically undetected leak, repeated clinical examination, repeated blood investigations, respiratory and renal support, resources for monitoring, and readiness to operate. It is easily understood that non-operative management can be more copious than surgical management. Various endoscopic methods have been attempted to deal with perforation: clipping, stenting, sealing with glue, and combined laparoendoscopic approaches. Yet, all these methods require training and expertise that is not widely available, and the existing evidence is insufficient to support them for generalized practice. Surgical management remains the gold standard in perforated peptic ulcer. Absolute indications are the presence of significant pneumoperitoneum, or extraluminal contrast extravasation in imaging, or signs of peritonitis. Prognosis after surgery is determined by factors relevant to the patient himself, ASA score, age, medication and comorbidities, but also by factors relevant to his status with regards to sepsis. This manifests as circulatory collapse, acidosis, organ failure, and hypoalbuminemia. All these are highly influenced by the time lapsed from presentation to the operation theater. So the answer to the question, when is the proper time to operate, is as soon as possible given the resuscitation targets. The next question is whether the approach should be laparoscopic or open. Laparoscopy offers less postoperative pain for the first 24 hours and fewer wound infection, but has no advantage on mortality, leaks, intra-abdominal abscesses, and reoperation rates. So given that the appropriate skills and infrastructure exist, the laparoscopic approach can be safely performed in stable patients, but not in hemodynamically unstable patients, or when severe cardiovascular and pulmonary comorbidities contraindicate pneumoperitoneum. The simplest method of surgical treatment is primary closure of the hole with interrupted sutures. This is indicated when the hole is less than 2 cm in size, the edges are viable, and can be opposed without tension. Selin-Jones repair is more widespread. This is primary closure of the hole with interrupted sutures, plus covering the suture line with pediclete omentum. It is considered the gold standard in both open and laparoscopic approach, again for small ulcers with holes not exceeding 2 cm. This has been debated recently, because it offers the same outcome with simple suture repair, while it takes more time. Nevertheless, this method is probably more helpful when the hole edges are friable and unable to hold the sutures. Another option is gram patch. A free omental plug is plugged in the hole, and secured in position with sutures, without any attempt of opposing the edges. This method is helpful in duodenal perforations larger than 2 cm, and when the edges cannot be opposed without tension, or are too friable to be sutured. The final method of surgical treatment is resection. Distal gastrectomy including the ulcer is the gold standard for perforated gastric ulcer, especially if it is larger than 2 cm. Pancreas-sparing duodenectomy can also be an option for perforation of the first part of the duodenum. Special consideration should be given to the possibility of malignancy in case of gastric ulcers. Adenocarcinoma is responsible for 10 to 16% of gastric perforations. If resection of the ulcer has not been performed for whatever reason, it is mandatory to take biopsies. When the perforation compromises the second part of duodenum, special attention should be paid to the ampulla of Vater. Pancreatiduodenectomy is far from the proper operation in the setting of perforated peptic ulcer. These lesions can be treated with duodenojejunectomy, or with pyloric exclusion and gastrointestinal diversion. However, this is not a very common situation and evidence is limited in literature. When the patient is hemodynamically unstable and too septic, the operation should not be prolonged, with the purpose of a definite solution. A life-saving damage control operation should be undertaken, followed by a revision after the stabilization of the patient. Postoperative complications after surgical repair of perforation range from 15 to 30%, and can be from the wound, such as infection, incisional hernia, wound dehiscence, or from the repair itself, such as leak leading to intra-abdominal collections or abscesses, enterocutaneous fistula, and peritonitis, or other, such as pneumonia, ileus, etc. Mortality after surgery for perforated peptic ulcer ranges from 6 to 10%, and is 3 to 5 times higher in the elderly, due to comorbidities, delayed or atypical presentation, and more than 24 hours for diagnosis. This highlights the need for early diagnosis, early resuscitation, and prompt intervention.